Thanks for asking me to talk about radiotherapy for treating Dupuytren's and Ledderhose disease. This is a webinar that is mainly aimed towards patients, but of course it might be of interest to medical professionals as well. Just to take you through my experience using radiotherapy for Dupuytren's and Ledderhose disease. I was appointed as a consultant oncologist in the Royal Surrey County Hospital in Guildford in the UK in 2010. And I started the Dupuytren's practice website a year later in order to offer people the option of getting radiotherapy for Dupuytren's disease, because it wasn't widely available, particularly at that time. I've also been a specialist advisor on patient internet forums. I was on the Royal College of Radiologists Review Committee, and we wrote a document in 2015 reviewing the use of radiotherapy for benign conditions, including Dupuytren's and Ledderhose. I've also been on NICE committee for this. I presented at the British Society of Surgery to the Hand meeting on a panel presentation, and I run a clinic weekly treating patients with Dupuytren's and Ledderhose disease with radiotherapy, but also other benign conditions, including plantar fasciitis and keloid scarring. Currently, I'm the UK lead for Genesis Care, which is a national and international private cancer care company for benign radiotherapy and also skin radiotherapy. And I've probably treated around 1,000 patients with radiotherapy for Dupuytren's and Ledderhose disease. So most radiotherapy in the UK is used as a high-dose treatment for treating cancer. Basically, it stops cancers growing. We tend to use around 60 gray, with gray being the unit of radiation that's given. But also, radiotherapy can be used for many non-cancer conditions. And that's because, first of all, it's anti-proliferative. In other words, it stops stuff growing. And also, it's an anti-inflammatory treatment as well. We tend to use much lower doses than for cancer, so anywhere between 3 and 30 gray would be the normal sort of doses, more towards the 30 gray for Dupuytren's and Ledderhose. And therefore toxicity and side effects, although we can get some side effects, they don't tend to be a major issue with these doses of radiotherapy. So I'm going to talk today about Dupuytren's disease of the hand and Ledderhose disease of the foot. So who gets Dupuytren's and Ledderhose? Well, there is a genetic predisposition, and particularly there's certain families have it more, and perhaps people from Northern Europe get it, and perhaps males more than females. That seems to be true, but I must say that I tend to see equal females and males in my practice. There's a wide range of people that get it in terms of their age. So the average onset for patients with Dupuytren's tends to be in their 50s or 60s, but I've seen people anywhere from their 20s to their 80s. It tends to be about 10 years earlier in Ledderhose, so it's a little bit more common to see people in their 20s and 30s with Ledderhose. Dupuytren's disease is actually very common. So we think perhaps approximately 2% of the UK population, and that's obviously a lot of people in the UK, given there are 60 million people in the UK. Ledderhose disease is rarer than Dupuytren's disease and tends to coexist in about 25% of patients. There are some conditions which are associated with Dupuytren's and Ledderhose. So Peyronie's disease is a very similar condition where you get a plaque that in the penis that is painful and can cause bending. That is an actual identical condition if you look under the microscope. There's a condition called Garrod's pads, which are on the back of the hand. You get them on the knuckles. And again, if you looked under the microscope, they're actually the same as Dupuytren's and Ledderhose. And also frozen shoulder is associated with these conditions. Other associations, as some people do have a family history. It's not necessary to have a family history, and sometimes, even though there might be a genetic component, it can actually miss out generations. So just because your parents or grandparents haven't got it, it doesn't mean that there isn't a genetic element to this. People who have diabetes are more likely to get it. People who do manual labour, and particularly vibrational labour, that's actually pretty well proven and something that people can claim for occupationally. Hand trauma, so particularly if you have trauma, for instance, surgery, or you break your wrist, but also blunt trauma. So for instance, mountain climbers tend to get Dupuytrens more than non-mountain climbers. Smoking is associated with this. Alcohol excess is a little controversial, but certainly having liver disease, in particular cirrhosis of the liver, is associated. And then there are also certain drugs and medicines that can worsen this. So let's talk about Dupuytren's disease to start. What is Dupuytren's disease? Dupuytren's disease is a benign thickening of the palmar fascia leading to fixed bending or contracture of the fingers. So you can see in the picture here that this is a nodule starting the palm, and then that then becomes a cord. So in other words, a linear thing that goes up to a finger, and also a cord that comes down the other way towards the wrist. That's an early cord. And then eventually that cord contracts and forms this fixed bending of the finger, which is we call the contracture. So biologically, we could divide it into two phases. There's an early phase where there's a lot of action going on. So the fibroblasts that put down the scar tissue proliferate. In other words, there are more of them, they're dividing. And there's an inflammation component. And that's where the nodules and the cords develop, and you get this skin pitting or skin retraction. So that is a phase where there's a lot going on, and therefore treatments such as radiotherapy may well be effective in that phase. However, in the late phase, where you actually see the contracture of the finger, that is actually less biologically active. And what happens, we think, is that the fibroblasts that give down the scarring turn into what we call myofibroblasts. And myo means muscle. And these fibroblasts basically are able to contract, and that forms the contracture. There are other theories of how this works, but that's one of those theories. So in this late phase, we think perhaps radiotherapy is not effective because it's less biologically active. So let's look at some pictures, which I got from the internet, of different stages of Dupuytren's disease. So you might be able to see there's a small nodule here. There's a cord, a proximal cord, in other words, going towards the wrist. There's a distal cord where the skin is being held down. And then you can see on either side, this sort of Y shape is actually normal skin that's sort of tented up because it's being pulled by this. Then you can see a little bit more advanced that there's skin pitting over here, what we call skin retraction. And there's a bit more disease over there and some obvious cords going to the fingers. This is a picture of Garrod's pad. So it's a very, very large one, probably the largest one I've seen. And they can cause some problems, particularly with making a fist, and they can become quite tender and they can catch on things. This is a little bit more advanced with some palmar disease, and you can see now that the finger is not able to fully straighten. And so that's a fairly early contracture, perhaps of 20 or 30 degrees. And this is clearly a very advanced case where someone's got cords and very advanced contractures in a number of their fingers. So the normal test that people use is called the tabletop test. So if you've got a contracture of a finger and you put your hand down on a table, you won't be able to flatten it. And you can see that over here. But there's actually an early test that I use where this is my hand and I'm lifting my index finger here, and that's called hyperextension. In other words, I'm able to get it past the midline. Now that hyperextension, before there's a contracture, that hyperextension reduces, and you can see that I can bend my finger back less. And then eventually I can't bend it at all backwards. Now, this person would not fail the tabletop test because they don't have a frank contracture, but they do already have loss of hyperextension, and that is really on the way to forming a contracture. So I think that's an important test that I tend to do. This is a bit medical, but we do classify Dupuytren's disease into various stages. Stage N is the earliest stage, and that's where we have nodules, cords, and skin retraction, but no contracture. The next stage, stage N1, is where there are nodules, cords, and skin retraction, and a very, very minor degree of flexion deformity or contracture, up to 5 or 10 degrees. It's very, very minor. And then the other stages is where there's more severe contractures. So traditionally, your GP or hand surgeon, when you have nodules, cords, and a very minor contracture, would say, look, there's nothing to do, you don't need any surgery, just watch and wait. And then at a later date, they would say, you've now got to 20 or 30 degrees, there's a problem with your fingers and your hands, so let's do either surgery or perhaps a needle, or there used to be an enzyme which we could use, and let's release that contracture so that you can get your hand back to normal. So that's what they used to say. In fact, what I'm going to talk about is that at this early stage, we can perhaps intervene with radiotherapy for some patients and prevent them getting to that later stage. So let's look at some evidence. I'm not going to go into too much detail. There's a professor called Professor Siegenschmidt in Germany who did a trial. And this is for patients with early Dupuytren disease. And what I mean by that is that they either don't have a contracture at all, or they have a very early contracture. So going back to the staging before, that would be stage N or stage N1. These are also patients where they have progression. What do I mean by that? There are some patients that get a nodule and it stays like that for 10 years. Those patients don't need treatment. However, there are patients, quite a lot of patients, who get a nodule and then another one, and then the nodules get bigger and they get a cord and it starts pulling on their fingers. Those are patients that I would say are progressing. In other words, their disease is worsening. And those are patients really that should be considering further treatment. So Professor Siegenschmidt compared two different doses, and we'll go through this in a little bit of detail. 30 gray, so remember gray is a radiation measure. So 30 gray against 21 gray. So comparing those two doses. All patients had progressive disease and they were offered either radiotherapy with one of those two doses or a watch and wait. And those were the control. But the watch and wait group were not randomized to the watch and wait group, and therefore there was not a randomized controlled study. So this study, although it's very interesting and useful and definitely guides people's practice, is a little bit flawed. So I think this is probably one of the explanations for why this hasn't been funded by the NHS or other public health systems in a wide basis. So it's a little unfortunate that the study was done in this way, but this is still, in my view, good evidence and certainly guides our practice. He followed these patients up for 8.5 years, so quite a long follow-up. There are later follow-ups, but I'm just going to tell you these figures. They're sort of the most straightforward ones to talk about. So this is the way he gave the treatment. So 15 gray and 5 fractions. A fraction is a treatment, and a treatment's given every weekday. So 5 treatments would be given Monday, Tuesday, Wednesday, Thursday, Friday, in other words, over 1 week. 15 gray and 5 fractions means that each fraction was 3 gray. So it's 3 gray every weekday for 1 week. There was then a gap of, at that time, around 2 months, although we tend to give 3 months these days. That gap is variable, and to be honest, there's no real evidence showing that a longer or a shorter gap is better or worse. But I would say that at least 2 months gap is probably the standard at this point. So I tend to say 2 to 4 months gap is very, very standard. After the gap, the patients were given 15 gray and 5 fractions over 1 week, and that's a total of 30 gray and 10 fractions. If you remember, they compared 30 gray with 21 gray. 21 gray turned out not to be as good, so I'm not really going to cover that in great detail at this point, although it is an alternative way we can do things and still get reasonable results. So this is the standard treatment that I use and most people use. So just to show you what sort of machines we can use, basically there are 2 main types of radiotherapy machines that we use. One is called a superficial or orthovoltage machine, and it's a low energy X-ray machine. And this is a machine that we use for skin cancer or for Dupuytren's or Ledderhose. Very, very straightforward, very simple. Advantages and disadvantages to it, but it works very well. We can also use this very complex machine called a linear accelerator. This tends to be the big machines that you get in cancer centers, and it's really designed to treat very, very complex things deep in the body. But it can also be used in a particular mode which delivers electron treatment, and that is a good way of treating the surface and just underneath the surface of the skin. So either superficial orthovoltage treatment, in other words, low voltage X-rays, or electrons, either of those are fine. So I wouldn't worry about if you're going to be offered one or the other. They're both fine and they both work equally well, and their side effects are very, very similar. So this is the results that Siegenschmidt saw at 8.5 years of follow-up. So I'll just take you through these. In terms of the progression, in other words, worsening of the disease at 8.5 years, those who did not receive radiotherapy, 62% of them got worse. Those who did receive radiotherapy with 30 gray, only 20% of those got worse. So in other words, the worsening of the disease was reduced by about 3 times by 8.5 years. Now, those who needed surgery for a contracture, 30% who were not treated with radiotherapy needed surgery for a contracture, and that was reduced to 8% by radiotherapy. Now, there are a few messages here. The most obvious message is radiotherapy reduces by about 3 times the risk of progression and the risk of needing surgery for a contracture. But the 2 other messages are, if you see that actually 38% of patients actually didn't get worse, even though they didn't have treatment. So there are a small number of people, or about 1 in 3, who actually the disease will stabilize and therefore actually don't necessarily need treatment. The problem is we have no idea how to work out who those patients are. So that's just an important message. The last message here really is that despite radiotherapy, still 1 in 5 people still progress, and 1 in 12 people still need surgery for a contracture. So this is not a miracle cure. The other thing I will say is that radiotherapy, while it looks like it's very effective in stopping progression and forming a contracture, it doesn't make the disease melt away. I would say probably between 50 and 70% of my patients say that the disease has got less tender, the nodules have softened a little, and perhaps they've got a little smaller. But that is by no means everyone. And I think the primary reason why we're delivering the radiotherapy is really to stop it worsening and getting contracture, rather than just to reduce the size of the nodules. So what sort of side effects? Well, acute means immediately during and immediately after the radiotherapy, and people do get a little bit of redness and dryness of the skin. Grade 1 means pretty mild. And so it tends to be a little bit like sunburn. So you might notice that the skin gets a little bit red and sore. It doesn't tend to be a major issue. Sometimes about, I would say, more than 25% of people in my experience do get dryness of the skin. And I just tell them to put a simple moisturizer on there, for instance, E45, that sort of thing. Most people find that that dryness will go, but about 15 or 20% find they have ongoing dryness in the long term, for which they need to put moisturizer on. Sometimes people in the long term also say, you know, my skin feels a little bit rougher or smoother or thinner or thicker, or sometimes even the color of the skin's a little bit different. Those tend to be minor changes, but that's certainly something I've heard from a lot of patients. The other thing I will say is about 1 or 2% of people do get more severe side effects after the radiotherapy. So for instance, you get more severe redness, or sometimes some blistering, or even that the skin can break down. I've got to say, I've seen that perhaps in 2 cases in the last sort of 8 years in my practice. And those were both people where there was a good reason. For instance, a builder who was lifting heavy concrete sheets, or someone who went sailing where the ropes were going through their hands, those sort of things, where they were putting a lot of stress on their skin. The last really important thing to talk about is that obviously radiotherapy is used in very high doses to treat cancer, but radiation also has the risk of causing cancer. Now, we've estimated that risk at about 1 in 5,000 risk for a 50-year-old man. And the average period between the radiotherapy and getting a mild skin cancer in that region is around 20 or 30 years. So obviously, that is very important if you're treating someone who's young. So if I'm treating someone who's, let's say, in their 30s, then that conversation is a much more important conversation to have in depth. And I would tend to quote a higher risk. So for someone who's, let's say, in their 20s or 30s, I might say it's between a 0.1 and a 1% lifetime risk. And for someone who's, let's say, over 60 or 70, I would really say it's important that you know there is a risk, but it's so small that it's actually difficult to measure. So that risk is very personalized, particularly according to age, but perhaps also according to other risk factors as well. So these are some quotes that I have from some of my patients, just to let you know. So I wasn't willing to just wait and see and risk ending up with hands like my dad. So often I get patients who have a family history and they're worried that their hands will need surgery, and often they come and see me to try and prevent that with radiotherapy. As far as I could see, I had everything to gain and nothing to lose. I think that was a very kind comment. I think it's important to know that there are potential side effects, and obviously you need to make visits and so on. But I think I would tend to say that for some people, there is a lot to gain and little to lose. One of my patients described it in more detail and said it was painless and unspectacular. And he had some temporary mild reddening. Several months on, a noticeable softening of my Dupuytren's disease. I've done all I can to give myself a chance of negating the disease process. And then the last patient here is, I truly believe radiotherapy has allowed me to enjoy my life to the full and without pain. This is a patient who did have pain in the nodules. To me, that is just wonderful. So for some patients, this really can be very good for their quality of life, and obviously for anxiety about what's going to happen in the future. So let's go back to that pathway. And I would say that from my point of view, the modern Dupuytren's pathway would be in the early stage where you have nodules, cords, and skin retraction, and either no contracture or up to 10 degrees contracture, that radiotherapy would be at least worth considering. Obviously, for patients who have a higher degree of contracture, then surgery or needle eponeurotomy are ways of releasing that contracture. And radiotherapy doesn't really have a role in the more advanced stages. So just to go over that, these are patients that I would consider treating for radiotherapy. So early Dupuytren's disease, obviously have to have signs of Dupuytren's disease, no contracture or early contracture up to 10 degrees. And I tend to say progression in the last 6 to 12 months. So just so that you know that if you progressed, let's say 5 years ago, I wouldn't necessarily count that as progression if there's not been recent progression. Let's go on to talking about Ledderhose disease. So clinically, this is a disease where you get lumps in the arch of the feet. When I say they may be asymptomatic, what I mean is sometimes people get these lumps, they're relatively small, they don't cause pain or discomfort, and really my advice is you do not necessarily need to do anything about them at all. And in fact, leaving them alone is probably the best thing you can do. However, sometimes these nodules can grow and cause problems, and sometimes they can also become tender. So people can get pain on standing, walking, running, and sometimes even pain at rest. It is rare to get stiffening and contracture of the toes like in the hands, and perhaps that's because we put weight on our foot all day, that sort of keeps the toes from contracting, whereas obviously our hands tend to be like this in this position, particularly when you sleep. But like with Dupuytren's disease, sometimes these things can settle down themselves and sometimes they can get worse. So there is variation in how people's disease progresses. And sometimes, as I say, it can just settle. Most of the time, the disease is pretty typical and it can be diagnosed just by an experienced person looking at your hands and feet. But occasionally, particularly if someone has a single nodule in the sole of one foot and no other disease elsewhere, then I will tend to do an investigation, either an ultrasound or an MRI of fine, just to rule out other different diagnoses. So a lot of patients can be dealt with conservatively, in other words, not really needing medical treatment as such. So avoiding direct pressure is the main thing. Obviously, when you put pressure on these nodules, they can become tender. And there are various ways of doing that, either soft inner soles. Sometimes you can get custom orthotics, so you can get sort of vacuum-made orthotics that really conform very exactly to the size of the nodules. They can be very helpful, although sometimes when the nodules grow, again, you have to stop using them. People sometimes use padding as well. I mean, the idea really is to take as much pressure off the nodule as possible. Sometimes people find stretching helpful. I must say, sometimes people say that actually makes them more tender, so different people find different things. There isn't really a standard medical treatment. Sometimes people have steroid injections, but I've got to say the reports have been that people find them quite painful, but they don't tend to be terribly effective, particularly in the long term. So often what happens is people go to their GP isn't necessarily so familiar with this condition, and they send them to a surgeon, and if they cut it out, which these days luckily surgeons don't tend to do, they virtually always come back. And they can actually come back bigger, more painful, and associated with scar tissue. So one of the really important messages here is don't get these cut out because it may become worse rather than better. There is quite a large operation called a radical plantar fasciectomy, where basically they take away the whole of the fascia from the bottom of the foot. It's a very big operation. And I'd say for most people it's a last resort because of all the potential side effects, but it can be quite effective actually in some people. So I would say if there's really nothing else to consider after all the other treatments, then I think it would be reasonable to consider that, but definitely not as a first operation. So let's talk about radiotherapy for Ledderhose disease. And again, this evidence was gathered by Professor Siegenschmidt in Germany in 2012, and he treated 158 patients and followed them up for more than 5 years. And these are patients, all of whom, again, have progressed over the last 6 to 12 months, and they had increased nodules and cords and increasing symptoms. Most have been treated with conservative treatment, as I said before. And they were told about the various options. And they were told about conservative treatments, so orthotics, etc., radiotherapy, and surgery. And after that talk, most of the patients chose radiotherapy. So more than 60% chose radiotherapy, and the other was form a control group. And I'll say again, this is a non-randomized control group, and therefore this is not a randomized controlled study. And I think this is one of the reasons why presently this doesn't tend to be funded by a lot of public health systems in a widespread basis. And his results you can see on the left. So symptoms improved in 79% with radiotherapy, in 19% with the control. So a few messages here. Clearly, radiotherapy improves symptoms in most people, and much better than those who didn't have radiotherapy. But interestingly, actually, 19% did actually improve by themselves without radiotherapy. So there's a small chance that without treatment they might improve, but of course, much greater chance that it won't improve without treatment. And that effective radiotherapy was translated into less pain on walking and also improved walking. Now, my results in my patients that I published a number of years ago when I treated around 50 patients with Ledderhose disease showed virtually exactly the same results. So 79 patients had improved overall and 20% of patients had not improved. Again, minor side effects in most patients. The side effects are virtually identical to those with Dupuytren's disease. And in summary, radiotherapy is a very effective and safe treatment for those patients with Ledderhose disease who have symptoms. So I thought it might be helpful just to go through a case study of someone who had both these conditions and just to go through some of the thinking that I went through and how to treat this particular patient. So this was a 45-year-old man. He previously had Peyronie's disease, so in other words, a plaque in the penis that caused problems there. His father had had advanced Dupuytren's disease, so he had a family history. 15 years ago, so when he was 30, he developed Garrod's pads, so the knuckle pads that were painful. 2 years ago, he developed nodules in his left palm. And 6 months ago, he had further nodules in his left palm. His fingers became tighter, and he also developed nodules in his right hand. I will say these are not photos of this patient. On examination, as I say, he had Garrod's pads. On his left hand, he had nodules, cords, skin retraction, all the things you would expect to see with Dupuytren's disease. And he also had loss of hyperextension of his ring and little fingers, so he was not able to get them past the midline. So he couldn't do this. They stayed on the midline. But he did not have a contracture. In his right hand, he had nodules, had cords, but no loss of hyperextension. So it was a little milder on his right hand. On his left foot, he had 2 nodules, and they were tender. So what was I considering when I saw this patient? So I was thinking, well, what's the likelihood of progression to contracture with no treatment? So would no treatment be a good option for him? If he did get a contracture, what would be the success of surgical release? So again, you know, is it better just to let him get a contracture and then send him to a surgeon if that was going to be very, very effective? Is there a treatment for Garrod's pads? What should I do about the Ledderhose disease, the nodules on his feet? And are there any other treatments available? So this were my answers to these questions. So it's important that I tell my patients that this disease has a variable course. In other words, some people do not get worse and do not get a contracture. However, this gentleman, he was male, had a young onset. He had it in both hands. That's what bilateral means. Ectopic means he also had it in places outside of his hands, so the Peyronie's disease, and also in the feet, and he had a family history. So all of those factors make him have what we call a Dupuytren's diathesis, which makes it, first of all, more likely he'll get the disease, but also more likely that it will get worse over time. So although I have to say it has a variable course, I think in his case, it felt to me like it was very, very likely to get worse. What's the success of surgical release? Well, a fasciectomy, which is the open surgery, has about a 40 to 50% recurrence rate. And, you know, it's a pretty large operation, and maybe you're out of action with that hand for 6 to 8 weeks. Having a needle is a less invasive option, but has a higher recurrence rate. So up to an 80% recurrence rate. So for a lot of patients, if you do leave them to get a contracture, it may well come back. And then ultimately you've lost the chance of giving radiotherapy, although there are some patients that we can give radiotherapy after surgery. What do we do about the knuckle pads, the Garrod's pads? Well, they tend to come back after resection. So you can treat them with radiotherapy, and that can be quite effective in quite a lot of cases. I would say, in my experience, about 70% of people. For Ledderhose disease, you can, of course, do surgery, but that can be disastrous. As I said before, it tends to come back. And is there any other treatment available? Well, of course, I would offer to him radiotherapy to all those parts of him. So in summary, the role of radiotherapy for Dupuytren's disease is for early disease, which is progressing, in other words, getting worse, for people with straight fingers or nearly straight fingers. It reduces the risk of contracture by about 3 times. It can also be used to treat painful nodules, and also can be used to reduce the risk of recurrence after surgery. For patients with Ledderhose disease, nodules on their feet, I tend to use it for people who have some discomfort or pain associated with the nodules, or where the nodules are growing. I don't tend to use them for people who have nodules that are not growing and do not have pain. Thank you.
Thank you very much for that. We do have a few questions that our members have put together for me before this talk. Do you want us to go through them now, or?
Absolutely, delighted.
I'll just have to find them.
Did that pretty well cover a lot of what you wanted, Anna? You
did.
Yeah, good. You might have disagreed with some of the things, I don't know. I don't know. I mean, there were some things I didn't go into just because of too much detail. Like, I didn't go into using radiotherapy after surgery. I didn't go into current trials. There's lots of stuff I could have talked about.
Yeah, but we also don't want to overdo it.
Exactly. That's what I thought.
So I think I will say, let's just touch on some of the questions. For instance, a lot of patients talk about treatment failure. Would you say if the disease is sent into regression and then maybe 2 or 3 years later it flares up again, is that treatment failure, or is it just natural progression of the disease that unfortunately can't be stopped completely with radiotherapy?
I think that's a really good question, and I suspect that the answer is sometimes one and sometimes the other. So for some patients, they do truly have disease that might or might not respond well to radiotherapy in the first place, and then gets worse. So I think there are some patients who do fail radiotherapy. And for some people, the disease just continues to get worse and continues to grow through the radiotherapy. So I would term that primary radiation failure. There are some patients who the same disease, so the same nodule, responds well, and then a couple of years later starts growing again. And I would say that's a secondary radiation failure. So in other words, it responded well and then secondarily gets worse. I think though there are some patients who have disease that I treat which responds well, and then many years down the line have new disease that forms that was never treated with radiotherapy in the first place. So I think, you know, that isn't necessarily a radiation failure, although that's arguable. I think also there's a fourth group of patients where you treat part of the hand and that disease responds well. And then there's another part of the hand where there's a new nodule. And obviously that's not radiation failure, it's just that disease starts in an area which wasn't previously treated by radiotherapy. Now, all of those patients I would consider differently in terms of what you do from there. Those patients who have disease that wasn't previously treated by radiotherapy, either on a different part of the hand or foot, or a different hand or foot, so in other words, treated the left and it comes back on the right, I would just treat them with radiotherapy in the normal way. So in other words, 2 weeks of treatment, standard way. If they have primary radiotherapy failure, in other words, it just never responded, then I just think radiotherapy is not really the right thing for them, in my view. If, however, they had a good response to radiotherapy and then at least a year down the line it comes back in the same area, then I do consider retreating those patients. But instead of using the 2 weeks of treatment, I'm very cautious and I only use 1 week of treatment. I have found that some patients have had a response to that, and I think it's worth trying, but what I would say is there is not really any evidence out there in the literature showing that it works, so this is somewhat anecdotal. But the reason why I use just 1 week of treatment is because I think the likelihood of it causing major side effects is also very low. So it's a little unclear what there is to gain, but I think I'm still staying within a fairly safe margin in terms of how much radiotherapy I'm giving. So I feel a little uneasy about people who would repeat the same dose of radiation. I think, you know, my worry is that patients will get side effects, for instance, with scarring and so on. But I feel comfortable giving half the dose the second time.
Great. Another question we get asked a lot is there any kind of condition patients might have that stops them having radiation, like for instance arthritis, fibromyalgia, anything that you would say, well, no, I don't even need to examine this patient because I know I'm not going to offer you radiation?
So there are certain very rare specific syndromes where you actually can't use radiation. So certain connective tissue disorders, but particularly things like ataxia telangiectasia, where people are so sensitive to radiation that it can cause damage. And that's something that all oncologists are very aware about. And if patients have it, again, I'm sure they will be aware of that. But what I would say is normal conditions like arthritis, diabetes, fibromyalgia, I don't really think there's any particular reason why you shouldn't have radiation in those cases. In fact, many years ago, radiation was actually used as a treatment for arthritis. And in fact, in various places in the continent, people who have bad osteoarthritis, who would prefer to not have surgery, actually are treated with a very low dose of radiation. So my feeling is that radiation is not an issue with osteoarthritis. And so in terms of local other conditions, the other thing I would say is if people have got open wounds, then I would be cautious because radiation can reduce wound healing. So for instance, patients who have surgery, I would tend to wait till the wounds are healed until I give radiation after that.
Right. But something like Raynaud's disease, you wouldn't worry too much?
No, Raynaud's is not a contraindication to radiotherapy.
How about fibrosis after radiotherapy? Would you worry about that? Do you tend to see that or not in the doses you use for Dupuytren's?
So fibrosis is a sort of medical word for scarring. And when we use very, very high doses of radiation, for instance, when we treat people with breast cancer or for skin cancer, because we're using such high doses, there is a small risk that we cause fibrosis or scarring. Now, in the doses that we use for Dupuytren's disease, we don't see that. So the chance of getting scarring as a result of radiotherapy is very, very low. I mean, I would never say never, but certainly not something I've seen. Another question connected to that is that people worry that if we give radiotherapy that the surgeons can't do surgery as a result. And they worry that first of all, wound healing would be worse. There's no evidence that that's the case. And also that if we cause scarring, that surgeons will find it more difficult to do their surgery. In fact, there are some surgeons that say that radiotherapy, because it actually reduces the scarring, in other words, reduces the amount of Dupuytrens, can actually make it easier. I mean, I've heard surgeons say both ways. Some are just worried. They don't have any evidence for that worry, but they're just anxious that their surgery will go well. I think it's a reasonable worry, but I'm not sure that there's necessarily any evidence for that worry. So what I would say is, if you find that your surgeon says that they don't want to do surgery because you've had radiotherapy, then there are other surgeons that will fill that gap. There are plenty of surgeons that will definitely consider either a needle or full fasciectomy if you've had radiotherapy before.
Good. You mentioned moisturizing your hands. Is it important for patients to only use a moisturizer after the radiation treatment and not, say, an hour before?
It's reasonable to use moisturizer during and after the radiotherapy treatment. It's probably not necessary during the radiotherapy treatment unless you already have very dry hands. But you need to be really careful what sort of moisturizer you use. Some of them have substances in there that can actually irritate the skin. So for instance, things that have perfume in, they can irritate the skin during the radiation, and obviously you can get worse side effects, so you need to avoid those. Some of them also have things that can actually increase the radiation dose to the skin. They can have various sort of metals in them. And clearly those are ones that you must avoid. So what I would say is talk to your radiation therapist, generally the people who work the machine, or the radiation oncologist. If you're going to use a moisturizer, show them which one you're using and ask before you use it during the radiotherapy. I would say after the radiotherapy, we're a little more relaxed about it, but during the radiotherapy, you need to be very careful.
So, for instance, people who use magnesium oil, which is quite popular at the moment to try and prevent contractures, that wouldn't be a good idea.
Definitely not. Mustn't use magnesium oil during radiotherapy.
Right. How about food supplements, curcumin? And
I think it's important to say that, whilst I'm not against using supplements in general terms, there is no evidence that these are helpful. And what I mean by evidence is not, that one patient or 10 patients find it helpful. It's really people who are trying these out in a controlled way, in other words, in sort of experimental clinical trials, making sure that first of all, they are effective, and second of all, that they're not harmful, because sometimes actually supplements can do more harm than good. I would say that in terms of using them during radiotherapy, again, please do not use them because they can potentially interfere with the radiation effect, either making the side effects worse or making the radiotherapy less effective. So during the radiotherapy, it's important that you do not use these supplements.
Great. I think we've covered all the questions there.
Fantastic. I thought there were going to be hundreds. That's good. Good. Okay.